now that we're all awake, we can talk about sleep. We all know that sleep is important. It's been mentioned many times at this conference already, so I won't harp on it. But I will tell you about the moment that it became salient for me just how important sleep is. So I was a researcher at Stanford, and I was working with Dr. Ian Gottlieb, and he was studying 2 cohorts of young girls. One cohort, their mothers had a history of depression. The other cohort, the mothers had no history of depression. And we knew that those girls whose mothers had a history of depression have are 3 times more likely to experience an episode of depression in their lifetime, even though they had never been depressed themselves. So the question is why? And we were looking at a ton of biomarkers in that lab. But there was this presentation about sleep. And when the girls were 10 or 11 years old, we looked at their sleep. No differences in total sleep time, no differences in sleep timing, but they were reporting just feeling worse sleep quality, just feeling like when they woke up, they wouldn't feel rested. And it clicked for me. You can just imagine how that's going to affect that girl's day, how it's going to affect that girl's week, their month, and the trajectory of their life, right? Why that might increase risk for depression. And it turns out that sleep is sort of this, what we call trans-diagnostic risk factor. So it runs across psychiatric diagnoses and health diagnoses. It's common in depression, it's common in anxiety, it's common in, it's associated with poor academic outcomes in kids, it's associated with obesity, it's associated with suicide. It's a really important risk factor that runs across all of these different issues. And it turns out that it's not just that it's happening concurrently with these issues, it's also happening prior to these issues. So that blue line across the top, those are ages. So in this study, we looked at kids when they were 10 to 13 years of age and followed them till they were 22. And we found that sleep problems at 12 to 13 years of age predicted and predated depression, anxiety, poor academic outcomes, obesity, and suicide risk. So this is a really important targeted point of intervention, which was exciting to me because in the world of psychiatry, we don't have a lot of those, right? And if you've ever walked into a classroom, you've seen this, right? There are kids falling asleep in class all the time. 45 to 70% of teenagers report some sort of sleep disturbance. That's over 16 million teens in the United States. But there's some good news here. Cognitive behavioral therapy for insomnia is the gold standard treatment for insomnia. It's recommended by the American Association of Physicians, the American Academy of Sleep Medicine as the first-line treatment. And this is a treatment that does pretty well in clinical trials. So I think Ashley Mason mentioned earlier that antidepressants only improve depression in about 30% of patients. Cognitive behavioral therapies for depression and anxiety, only about 40 to 50% of patients. But cognitive behavioral therapy for insomnia improves like 70 to 80% of patients. That's pretty good. We don't have to reinvent the wheel. We don't have to create some crazy novel technology here. But this is where the voice of Tom Insel pops into my head. And I don't know if Tom Insel is here today. I saw him yesterday. But if you are, I want you to know your voice is in my head. When I was at Stanford, he spoke to our class and he said, if we just did the treatments that we knew in the 80s worked, if we just got those to the people that need it, we would have moved the mark centuries in mental health. You know, our pace has been very slow in moving the ball forward in mental health. If we just got those treatments out, that would be huge. And this is where the big problem is. There's only about 500,000 mental health professionals in the United States. So remember that number, over 16 million kids. There's only a little over 2,000 of them that specialize in children and adolescents, that are equipped to deal with children and adolescents. There are only 412 registered sleep treatment providers in the United States. My wait list, at UCSF is a year and a half long. I'm not scalable. We need some sort of force multiplier to move this ball, right? And enter this picture, right? Cell phone use among teens is ubiquitous, we all know it, and unfortunately it's associated with some of the mental health crisis that's going on. But what if we used that captive audience as a force for good as opposed for evil, right? In adults, cognitive behavioral therapy for insomnia has been moved into a digital health platform successfully. So Somryst is available now via prescription. They have FDA approval. They're developed by Parapharmaceuticals. Sleepio was developed by Big Health. These are commercially available platforms, and they really work. But for teenagers, there's nothing. So we can't let these kids be left behind, and I took a scrappy amount of money, $2,000, and I created Bright Mobile. Bright Mobile, we conducted a small, well, it's not that small, I guess. It's 53 kids, an open pilot study, and we were testing their pre-post outcomes for these kids. And along the y-axis, you can see sleep quality index scores. A higher score here is indicative of actually worse sleep, so more sleep problems, and a lower score is indicative of better sleep problems. On the left is our baseline score, and on the right is our post-treatment score. And you can see that there's a significant difference here between baseline and post-treatment in terms of sleep quality. Kids' sleep are improving. And similarly for depression outcomes. So along the y-axis is depression severity, so a worse score is a higher score. And again, we see improvements in depression. And this is exciting because this is not neurosurgery. This is not creating new retinas. This is taking existing technology, taking existing treatments, and getting them out there to the kids that need it. We're conducting new studies now with randomized controlled trials looking at whether Bright Mobile can prevent depression and anxiety among teens. And we're now proposing to work with the governor's office to try to get Bright Mobile into school districts to get this treatment to teens that need it. And we were fortunate enough to get money from UCSF Innovation Ventures to develop a new and much cooler Bright, which was definitely in need. And we're really excited about the possibilities of moving this forward. We really want to take this forward to get it out there to the kids that need it. We would love to talk with people here today who are experts in the field. We really need advisors to figure out how to get this to a scalable level. And I just want to highlight that this isn't just about sleep. Sleep has this domino effect, right? When you're improving sleep, you're improving depression. You're improving, parents reported that they got along better with their kids. Kids reported that they were more likely to seek out mental health care in the future because of a successful treatment with Bright Mobile. This is a real force multiplier, right? And it's a low stigma point for teens to get involved in mental health care. And so I want to just end by saying, the kids are our future, right? And I don't mean to be cheesy, but they really are. And this generation of children have enormous challenges to face. So we need to help them be well-rested, calm, and able to think for themselves critically to evaluate the world and solve these big problems that they're going to face. So join me. Thank you so much.